Hello, everyone. Good afternoon. Good afternoon. Good. I'm really happy that we're all filled, and looking forward to a very exciting discussion this afternoon. My name is Chisom Obi-Jeff. I'm from Brooks Insights in Nigeria, and I'm really honored to be moderating this section. And for today, we'll be talking about a very crucial topic that holds significant implications for public health and the well-being of individuals across the globe. In our time together this afternoon, we're going to delve into three fundamental aspects of life course immunization central to the core issue we aim to address today. And they are sustaining demand during epidemics, rebuilding trust in vaccines, and addressing specific challenges in vaccine confidence and acceptance. So I encourage you all to please listen to our panel of experts as they're going to share their invaluable insights, experiences, and research findings on life course immunization. So without further ado, I'd like to introduce our panelists for this session. So I'd like to introduce Dr. Richard Kabanda. Dr. Richard Kabanda is the Acting Commissioner, Health Services, Health Promotion, Education and Health Communication, Ministry of Health, Demand. Please welcome Dr. Richard. So second up for among the panelists is Dr. Rupali Limaye. She is the Deputy Director, International Vaccine Access Center at Johns Hopkins Bloomberg School of Public Health. I'd like to welcome on stage Dr. Rupali. Welcome. Up next is Dr. Mark Donald Renosa. Dr. Mark is the Supervising Science Research Specialist, Department of Epidemiology and Biostatistics, Research Institute for Tropical Medicine, Department of Health, Philippines. Welcome, Dr. I would also like to introduce on stage Dr. Limaye Leader, Research Physician, Public Health Research Institute of India, Knowledge and Acceptability of HPV Vaccination. Please welcome. So unfortunately, my next panelist is not here. Okay, so before that, I would like to introduce Dr. Heather Lanton. Dr. Heather is the co-director, Social Science Research Council of the Mercury Project. Welcome, Dr. Heather. So although our next panelist is not here today, but I'd also like to welcome her. That's Dr. Heidi Lassen. Welcome, Dr. Heidi. Let's welcome her, although she's not here, but she's listening. Okay, so we've taken 8 minutes out of our time, so we'll just go right into the presentation. So our first presenter would be Dr. Richard. We're going to begin with him, where he's going to speak on the dynamics and innovations of creating and sustaining demand for vaccination programs during epidemics. So we're going to hear from his experience working in Uganda, which has multiple epidemics. So we saw Uganda with the Ebola Preparedness in 2019, the COVID-19 2020 to 2022, and then the Ebola outbreak 2022 to 2023. So welcome on stage, Dr. Richard. Welcome.
Thank you, Moderator. My presentation is based on some insights on some of the key public health emergencies that we have grappled with. I know at a global level, all countries have gone through COVID-19. Whereas COVID-19 is intense, but when you talk about Ebola, it brings fever to many people. But we have gone through a series of epidemics in our country, given the fact that Uganda is a landlocked country and we are prone to epidemics. Now, of course, given also the environment that we are living in with our neighborhood. So a deep reflection based on the topic is on pandemic preparedness, vaccine access and delivery, and decision making. So I just had some few insights on some of the key issues that we have kept our attention to when it comes to preparedness. Usually the attention is more on disease surveillance, and disease surveillance can easily trigger different issues when it comes to use of vaccines. Components of application to be able to receive vaccines or to receive resources for operations, but also there are components of readiness of districts or local governments, and there are also components of rollout. So all of those key issues need to be factored in. The other key major issue is the component of public health risk communication, which is self-explanatory. In preparedness, there is little of community engagement and more of generic public health risk communication. There are also components of health systems readiness, which should be well conversant with. And then also, there are also components to do with health advocacy across all different levels. And the other key issue is on vaccine access and delivery. Usually the component of demand, when we talk about it, people think more about components of advocacy, communication, and social mobilization. In a narrow kind of sense, but deeply, you need to look at health workers' prioritization as a key population for increased knowledge acquisition, capacity building, engagement, and their motivation. Especially when you have epidemics, even health workers these days really feel shy, especially the new breed of health workers who have just been taken through the theoretical frameworks of some of these epidemics. There are components of long hours of service delivery, because in many countries, it's not possible to deliver services 7 days a week. So usually, and not the entire day. And given the current work frameworks, many people would be interested in accessing services all the time, whether it's day or evening hours, weekend. So there are components of vaccine availability. Sometimes vaccines may not be available, so the teams must be able to factor that in the preparations. But of course, also there are components to do with the static service delivery, vis-a-vis the outreach model and the door-to-door frameworks. So all of those have to be factored in. Now, the other issue which may be an area of further discussion is the frequency of vaccine administration. Maybe those who are involved into the HPV space, you must have taken note of that the first dose is usually high, second dose is low. Maybe what is most appropriate is that many people would like to have a single dose kind of stuff, which is easier for administration. In terms of decision making, we need to think about components to do with effective, purposeful, and high intensified messaging in a relatable and contextualized manner. So that means that most of our content must be in the local languages, must speak to our cultures, must be acceptable. And the other core component in decision-making is the analysis of key stakeholders that can easily spice up decision-making processes for individuals in communities, as we shall see. And then the timely and meaningful engagements with the communities. So paying attention to timely and meaningful. How best can we be able to do this? So, but we know that epidemics bring to space so many issues. There is individual and community panic, depending on the nature of the epidemic. There is fear for unknowns, like economic hardships. So that has a lot of impact when it comes to what people would be able to decide. Misinformation and disinformation is usually high because of the panic, because of the unknowns. Service deprivation is also usually a very big issue during epidemics, that many countries, many governments, many response teams tend to focus on the major public health area of issue and tend to neglect routine service delivery. There are components to do with vaccine safety and effectiveness, which are very central now. And with epidemics, the introduction of vaccines, it is something that we need to tackle. So we had new vaccines when COVID was here. During Ebola, many researchers introduced some vaccines that are still on trial and all that. And so any other new introduction of any type of vaccine leaves communities in suspense. There are usually so many questions, whether you're doing research, whether. So, but again, emergencies come with mistrust from most governments due to public health policy decisions, lockdowns, partial lockdowns, geographical lockdowns, and all that. So we borrowed a leaf from COVID, where we had total lockdown and actually imposed it in Ebola. That's why we are able to manage the response within 69 days. So we did borrow a leaf. So that brings a lot of mistrust from government. So with all that, some of the key strategies that we need to look into are the intensified public health awareness and risk communication, the components of community engagement. Epidemics also require a lot of social listening and evidence generation. Social listening is very, very critical. So once you are not in touch with what is happening at community level, chances are high that you are failing the response. And that way, it's very difficult for you to roll out immunization or vaccination programs. Advocacy at all levels, we tend always to capitalize on advocacy at high level, at policy, parliament, or all that, ministers, because we want resources and all that, and political will. But we need to have advocacy at all levels, depending on the key issues at hand. There are issues to do with strategic engagements and coordination of partners. Usually during epidemics, partners mobilize a lot of money. Actually, taking Uganda as an example during EVD, when we declared that we don't have Ebola anymore, some partners were not even very happy. Some of them had just received a lot of resources. And actually now spending their resources was a big challenge. So, and they tend, if you don't do good coordination of partners, because 70% of the resources during epidemics come from partners, not from governments. And because they have the money, they want to take lead, yet government should take lead if you have the response. So that is really very critical. The components of public relations for building trust among citizens is very critical. There are components of capacity building for health and non-health professionals. There is a tendency of thinking that health workers know it all. During epidemics, don't make assumptions. There are so many unknowns, so you don't have to take chances. Health workers must be one of the priority groups that you must be able to target. Community-based health promotion initiatives, integration of routine service delivery, depending on the issues at hand, and then from the health promotion perspective of public health, our interventions, community interventions, must be driven by data, by science. So and understanding of some theoretical frameworks is very, very critical in the layout. So some takeaways that we need to look at: high levels of political will with government taking lead is very critical, however much partners may be having resources. Partner engagement, as I said, coordination and support for implementation. There are components of good technical coordination. Usually in some countries where we have visited, you find out that different pillars are implementing in silos, which is very, very dangerous. So you must be having high-level sense of good technical coordination. Data-driven performance with the targets from implementing partners, because if you have, say, new vaccines in place, implementing local authorities need to be provided or given targets. That's one way how they should be able to incorporate this into routine service delivery. There are components of evidence generation, as I said, and also professional mix for intensified and relatable engagements. We tend to think that because we are health workers, we know it all and everything must be done by us. If I could even ask that how many non-health professionals who are here, you may be shocked that majority are scientists. So the understanding of bringing other professionals on board to synergize what the health experts are doing is very, very critical. And then second last is the dynamic health communications. There is a thinking of, in many of our countries, low and some middle-income countries, internet access is very low. The elite think that social media can do wonders. It can among the few, the minority group, who influence a number of things. But real community work requires understanding of community communication mechanisms and being able to apply that. So we need to critically look at some of the traditional mechanisms that are available. Functional Public Health Relations Office for rumor management and etc. And then lastly is the component of full involvement and ownership of vaccination programs by non-health actors. There is a very big tendency of us medicalizing public health. That's why SRH issues, vaccination issues, we tend to think that we are the ones who should be able to take lead, which I think that is completely very wrong. Our role may even be like 30%. Provide the technical knowledge, provide the vaccines, and do the vaccination. So what drives demand is now the role and responsibilities of other actors at the community level who have never done public health, who have never done nursing or medicine. And we tend to forget that. So we need to put them at the forefront and ensure that they are the lead and we are at the other side providing the technical support. Then lastly is communication for vaccination programs should be informative in nature, but believable. There's need to provide facts, so it should be factual. It should be serious in the way it is laid out through available legal frameworks. In our country now we have the Public Health Act, so now it stipulates very well the roles and responsibilities of parents, and then should also be empathetic. Thank you for listening to me.
Thank you so much, Dr. Richard, for that insightful presentation. So we're going to take down our questions, and at the end of the presentation, we can ask our questions. So we know we've lost gains in vaccination due to the misinformation and COVID-19 vaccine. And it's really important at this time for us to think about how we can rebuild trust in science broadly and vaccines specifically. So we know that there are new vaccines in the pipeline right now, and this is the time for us to focus on vaccine readiness. This includes the vaccine demand, the demand side factors, the health system factors, that's the supply side, as well as placing the community at the center of our work. So our next presenter, Dr. Rupali, will talk us through the importance of having community at the center of our work and what we need to do, to drive demand for life course immunization. You're welcome on board, Mr. Dr. Rupali.
Thank you so much, and thank you for allowing me the opportunity to speak with you today. I'm here on behalf of the Johns Hopkins Bloomberg School of Public Health. Very excited to be here to talk about future vaccines. I know that we're still trying to think through how we can recover gains in routine immunization, but also to think about some of the new products that will be available and how we can get individuals to accept them. All right. So I think everyone in this room is pretty familiar with regards to, I think, the havoc that COVID-19 has really, brought for childhood immunization, but as well as coverage related to adult immunization when we're thinking about other antigens within the overall pipeline. You can see here on this slide, if we look from 2000 to about 2021, the top line is looking at global coverage in lower income countries, and then the global average, and then the blue line is specifically looking at lower income countries. And so the argument here is obviously we've seen huge issues with inequity with regards to COVID-19 vaccines, but there's also huge issues in inequities with regards to the coverage and the drops that have happened simply because of COVID disruptions. So what I'm going to talk about very briefly today is I want to talk about vaccine readiness and what we need to think about when we're thinking about getting countries ready for new vaccines that are coming down the pipeline. Although I know that this session is focused on demand, I want to spend just a few minutes to talk about the health system factors and how we can think about these as we're moving forward, including additional adolescent as well as adult vaccines, as well as maternal vaccines that are coming. And then I think, to me, the greatest thing of all of this is that this is a really nice opportunity. This is a time for us to pause and reflect and think about the ways in which that we can actually rebuild this trust that we have lost simply because of the way a lot of the COVID-19 vaccination programs rolled out and eroded trust in a lot of communities. So let me talk about the demand factors. I think everyone in this room is very familiar with the 5 C's model. So thinking through and talking about some of the different ways that individuals are making decisions with regards to whether or not they're going to accept a vaccination, whether they're going to delay, or whether they're going to refuse a vaccination. And so I won't spend a lot of time on this, but thinking through these 5 C's, so complacency, confidence, collective responsibility, i.e. norms, calculation, whether or not you're able to get the information you need to actually make an informed decision. And then, of course, convenience, whether or not it's available, whether or not it's accessible, and whether or not the cost is going to be an issue or not. Another way to think about this, I'm a behavioral scientist, and so the way that we think about this when we talk to individuals with regards to that might have concerns or safety issues related to vaccination is through a socio-ecological lens. And one thing that I think is very important here is that the individual level, I think, is very self-explanatory, so the attitudes and beliefs that the individual has. One thing that I think is key, not only with our current vaccination program and schedule, but for future vaccinations is going to be that interpersonal level. Everywhere we go, we have been told in every single country that we work in, it's important to talk to the male partner, the mother-in-law, the sister, whoever that may be. But then at the next level, also thinking through, and a lot of the presentations this morning focused on this, how do we make sure that healthcare workers are not stigmatizing with regards to individuals that are coming in and might have questions about vaccination? And then, of course, at the policy level, thinking about access issues, availability issues, as well as mandates, and how that really does affect decision-making at the individual level. So pre-COVID, essentially, when we talk to anyone, and this is primarily related to childhood vaccination, but this also does feed into some of the work with regards to adult vaccination, there was essentially 4 key reasons why individuals would tell us why they would not want to get a vaccine. The first had to do with ingredients. People had a specific concern about a specific ingredient that was used in a vaccine. The second was the schedule. We heard this over and over and over again, particularly from a parental point of view. Why is my baby getting 2 shots at this visit? Why are they getting 4 shots at this visit? I'm really concerned about the number of vaccines that you're asking me to give my child. The third was really this misperception that has continued to linger of vaccines and adverse events. So this idea that a vaccine can cause autism, a lot of individuals still do bring this up to this day, fertility, all of the other myths that we have here. But then the last was really focused on low levels of risk perception. So thinking about susceptibility to the vaccine preventable disease, but also thinking about the severity of the vaccine, the disease. So many individuals would say, I've never even heard of rubella. Why do I need this vaccine? And I've never even heard of anyone dying from rubella. So again, it doesn't seem very severe to me. So thinking about susceptibility as well as severity. Now, I think we have added a couple of new drivers post-COVID that I think were lingering in the background, but I think have really been highlighted through COVID, and I would really characterize them as polarization and misinformation. So I want to spend a minute and talk just briefly about polarization. So one of the things is that there was an argument that with regards to political ideology, whether or not that was predictive of whether or not you would accept a vaccine. Meaning, if you were more progressive in your political views, you might be more likely to accept a vaccine. The argument when this work was starting to be done is that this was very much focused on the higher income setting. Unfortunately, this has now bled into lower and middle income settings as well, that we're starting to see that less and less people are engaging with individuals that have different views than they do related to vaccination. So what I'm showing you here, this is just a snapshot of a study that looked at one day with regards to a cluster of individuals within a social network. So the blue dots essentially represent individuals that are pro-vaccination. The red dots represent individuals that have more anti-vaccination beliefs and attitudes, and your green dots are sort of the undecideds. Curious, what do people take away from this? There's a polarization. And what's interesting is that if you map this over time, you actually see that the polarization is getting farther apart, meaning that we're in echo chambers now. So we're not really speaking or engaging with individuals that might have different beliefs than we do. Another issue, and I know the previous speaker also spoke about this, is misinformation. So this was actually the word of the year for dictionary.com in 2018. And one thing that has been, I think, very clear and a real challenge with regards to vaccine acceptance is that not only is there a lot of misinformation, but there's a lot of information that is misinformation that is inadvertently shared. Meaning, you don't know if it's true, you don't know that it's false, you're not necessarily spreading it with negative intent, but you end up spreading it because you think you believe that it's true. One of the issues that we have faced, and I think many of us are working with social media companies with regards to how do we crack down on a lot of this, it's a slippery slope. It's also, I think, a policy and legal regulatory bed of whatever, can of worms, whatever you want to call it. It's really hard to think about how do you persecute individuals that might be spreading misinformation that could lead to harm. And so this is a key issue with regards to, I think, that has really increased. The other piece, and while I do think, and it's been quite amazing, that the participatory nature of social media has allowed people to get a lot more information very quickly at their fingertips, it also has allowed for a lot more misinformation and disinformation. So it's a double-edged sword, if you will. And with regards to the COVID-19 pandemic, what we also learned is that many people were very uncertain because there was lots of information coming out. And as a result, from a psychological perspective, people and humans generally want to do anything to reduce that uncertainty. That's what allows people to listen to conspiracy theory and start to think more and more about misinformation and why it might be true. So let me spend just a minute and talk about the health system factors that we do need to think about when we're thinking about any new product or any current product that we have in regards to EPI programs. So not only thinking through logistics, thinking through supply, engagement, of course, coordination across different multi-sectoral collaboration, I would say, but also planning. The biggest driver that we have seen on the health system side, as I would say it, would be the distrust in the healthcare system. And I think many of you have already alluded to this and have talked about this in the individual and respective countries that you work in. But this is just one piece, and this was from a 2022 study that essentially looked at the effect of trust with regards to the COVID-19 pandemic. So I pulled some of the countries on the bottom you can see here, but overall, 52% decreased their confidence that their healthcare system is well equipped to handle any other health crises. So we saw a huge drop in this. We had been seeing a huge drop in this in the 20 years prior. There was a decline in trust in healthcare systems, and then COVID essentially really exponentially, I would say, really decreased and sort of impacted trust in healthcare systems. So, while I think there are a lot of drivers that we're now dealing with that we saw before COVID, we added some drivers with regards to concerns related to whether or not someone would accept a vaccine. I do think that we're at an opportunity to rebuild trust. This is a great time for us to think about how do we engage in communities. So I'm very excited. There's a number of new vaccines that are in the pipeline. I've put some of them here. RSV, excellent news that came out just recently earlier this year that fingers crossed there will be a product available. There's already a product available for older individuals, but hopefully by next year, if things go well, there will be an RSV product available for pregnant women. So a huge, huge benefit if this is going to happen. Group B strep, we're a little farther out. At this point, the estimate is somewhere between 8 to 10 years before we see a vaccine. However, there's at least candidates in the pipeline, so I think it's something to be excited about. CMV, similarly, we have a little bit of a way to go. Zika, we've seen a lot of progress. TB is one that, we currently have something like 17 vaccine candidates in the pipeline with several of them in phase 3. This year, we will be able to, I believe, we'll see the results from one of the trials that is happening through the VPM 1002 study, and I think everyone that works in TB is sort of waiting with bated breath to see what these results might look like, with the hope that if the safety and efficacy results are looking relatively well, that we'll hopefully have a product to be able to start to offer countries within the next couple of years. I think people are probably familiar with the RTSS product. There's a second malaria product that is coming out that has shown, I think, increased efficacy as well as essentially some cost savings. So these are just some of the vaccines that are in the pipeline that we need to think about. So as I mentioned, to me, this is a nice opportunity. Vaccines don't save lives, but vaccination does. And we have to think about the ways in which just because a product is available doesn't necessarily mean that people are going to seek it and that people are going to accept it. And so for me, what we are currently doing through a number of grants is we're trying to very much take an implementation science lens to think about how do we actually develop demand for future vaccines. But in addition to that, how do we also make sure that health systems are able to deliver future vaccines? One of the key things, and again, I think from COVID-19, we have a lot of learnings related to how do we deliver an adult vaccine at scale, at a country level. And with TB vaccines, we're going to very much struggle with this. And we can learn a lot, not only from COVID, but obviously from the HPV work with regards to delivery of adolescents. So one key thing, though, has to be, and I think we've heard this over and over again, is that community engagement has to be at the center of all of this, even in terms of products that might be 8 to 10 years away. That's the only way that when a product becomes available, we will actually have individuals that will seek it and that will accept it. So one thing, just some key things to consider as these new vaccines are coming down, and we're going to have to start to think about how do we talk to countries, how do we talk to NITAGs, how do we talk to RITAGs and EPI managers, is first of all, which populations will most benefit from the vaccine? Understand, of course, the determinants, so going back to the 5 Cs model, but also thinking about perhaps the socio-ecological model and thinking about the peer influence specifically that's going to be critical. But also making sure the manufacturing space of all of this is that how do we work a little bit more closely with vaccine manufacturers that are particularly manufacturing vaccines that might be available in the next 2 to 3 years so that we can have, I think, a much cleaner and a much more efficient regulatory and policy pathway, because that is going to be, I think, really the holdup, and that's what we saw with a number of vaccines. So one piece of how we're doing this, there's a couple of studies that we had, and I don't want to spend a lot of time, but we have a 5-country study currently that is essentially looking at pregnant and lactating women in Brazil, Ghana, Kenya, Pakistan, and the Philippines. And this is part of another parent study that I have. But what we decided to do is that because we knew these new vaccines were coming down the pike, and it was important for us to better understand how do women feel about these future vaccines, the sort of last piece here on the bottom, what we decided to add into this study was really explore vaccine intentions for vaccines for the pregnant and postpartum women, just to get a sense of what women are feeling and what they're thinking. In terms of where we are on this, and Prachi is in the audience as well, who works on this study, we just started data collection. We'll be done with data collection at the end of the year, but at this point we're very excited because we'll have a relatively robust sample size and we're doing a mixed method study. But the way that we're doing this, if you're interested and thinking about, okay, I already am working with populations, can I get a better sense of how to assess vaccine intentions for future vaccines? We're doing something called a discrete choice experiment, and I'm happy to talk to anyone that might be interested in this. So what we're essentially asking individuals to do, we're asking them about future malaria vaccines, TB vaccines, RSV vaccines, and Group B strep, particularly in this study. And we're essentially giving them different hypothetical scenarios. So if a vaccine had efficacy at this level, if it had duration of protection at this level, what are all of these different factors? And what you can do is you can weight those factors to best determine what an ideal vaccine candidate or profile should look like to predict acceptance. And so we're also measuring hesitancy, so we'll have a better sense after this study of what this looks like. But this is just one of the studies that we're working on, and in addition, we have several, we'll do a 6 to 8 country study related to TB vaccine readiness, and that will start actually next year in 2 countries. So just getting a better sense of how do we prepare these systems. So I think really in conclusion, as I mentioned, I really think it's a time, it's an opportunity to think through how do we actually rebuild some of that trust. But to me, the most important thing of all of this is that through all of this different work, whether we're doing readiness work for new vaccines, whether or not we're thinking about recovery related to routine vaccination as well as HPV, how do we make sure that in all of these situations and through all of this planning that we are including key beneficiaries, including those that are affected by the disease and their caregivers? Because they have to be in every single step of the process. The other piece, as I mentioned, because there is such a lag from a policy and regulatory aspect, making sure that we're engaging with vaccine manufacturers very, very, very early to make sure that we can try to streamline that process a little bit and make it a little bit more efficient so that once a product is actually pre-qualified, it doesn't take 2 years to actually come to market. In addition to that, of course, working with the Vaccine Alliance partners, thinking about intersectoral collaboration with regards to ministries not only of health, but across the different ministries, and then, of course, working with the different decision-making boards and professional organizations. So in conclusion, I just want to make a few points here. I think we all know that the development and introduction of new vaccines that are safe, that are effective, that people feel comfortable taking are going to be crucial for disease control. In addition to that, there's many vaccine development challenges, which I'm sure many of you are aware of. So not only a diversification of funding, but again, thinking through how do we make that regulatory and policy pipeline much more efficient. In addition, thinking about how do we engage with stakeholders now, even for a product that might not be available 8 to 10 years from now, is going to be critical. And then finally, making sure that we're looking at this through sort of an implementation science and research lens to think about not only the demand side, but also the health system readiness side so that we have delivery mechanisms to actually deliver these products once they're available and they're on the market. So thank you so much.
Thank you so much, Dr. Rupali, for that exciting presentation. So quickly, we also know that there's been a dramatic decline in vaccine confidence and uptake in Philippines, and it has been linked to the dengue vaccine controversy in 2017, which spiked widespread distrust in childhood vaccination and led to large-scale measles outbreak and loss of a 20-year polio-free status in 2019. Since morning, we've been hearing about, the human-centered design approach and using it to, design tailored and targeted intervention. So informed by human-centered design, our next presenter drew on local narratives to co-design, co-refine, and test a story-based intervention that connects vaccine-hesitant caregivers and families, healthcare workers, policymakers, and other community actors. So up next, Dr. Reynosa is going to discuss the vaccine confidence randomized control trial results in rural and urban communities in Philippines. You're welcome, Dr. Reynosa.
Thank you very much. Good afternoon, everyone. In an ideal world, mothers or caregivers would pursue childhood vaccination to protect their children against infectious diseases, to thrive and achieve optimal level of life. However, mothers are now pushing back and questioning the true intent of our vaccination program in a society marred by generational trauma, distrust, systemic inequities, power imbalances, and misinformation. Therefore, vaccination programs, and our traditional approaches to global health clearly requires reimagination, more so the development of a deeper contemporary meanings to guarantee survival in these crucial times. Imagine a world where every innovation, every solution, every experience is crafted with one element in mind, the human element. A world where the voices of end users, consumers, communities are not only heard, but celebrated, valued, and cherished. This is the world of human-centered design and participatory approaches, an ever-evolving landscape where the true essence of intervention design resides. For this afternoon, I would firstly unpack the challenge at hand, the case of vaccine hesitancy in the Philippines, a point and example where a complex challenge demands nuance and empathetic approach. Second, we will embark on our methodological approach, our potential solution to this complex challenge. And lastly, we will be discussing accelerating initiatives, ways to move forward, and potentially embedding human-centered design within the fabric of our community interventions. Our challenge, the dramatic decline in vaccine confidence and uptake in the Philippines is linked to dengue vaccine controversy in 2017. Vaccine confidence plummeted from 93% of strongly agreeing in 2015 to 32% in 2018. This led to the erosion of, or this led to having our polio-free status and sparking measles outbreaks across the islands in 2018. While human-centered design has proven to be beneficial in developing vaccine promotion material, scholarship from low-income settings remains limited, and evidence did not always acknowledge vaccine-hesitant families' own lived experiences. With that, on that vein, we've implemented Project Salubong. Salubong is the moniker of our research is a Filipino term that means to welcome someone into one's life. It is intertwined with notions of acceptance, compassion, and understanding, and we send a message that we will not be relying only on blunt tool of scientific evidence without considering the vulnerable population's perspective. We wanted to understand the local narratives. We wanted to co-design and refine interventions with them and test with the people for us to build a meaningful campaign that revives faith in vaccines. So we definitely put community at the center of our project. However, we've started our project end of 2019 to 2020, the peak of pandemic. So amid the pandemic, we've developed new operating procedures for conducting online data collection to ensure that we gather quality data. We have published our methodological approaches in BMJ Global Health and BMJ Family Medicine and Community Health. For the first phase of our human-centered design, we wanted to understand first the current program. We've interviewed policymakers to really understand the dynamics, the context, and the challenges in recent years, from the Dengvaxia controversy to the recent challenges. We've published an article entitled Misinformation in Fighting Backlash and an Endless Recovery, and this figure outlines the processes that policymakers experience, regardless of age, gender, years of experience. The policymakers describe a sort of an immutable process that narrates the entire experience within the acute vaccine-related discourse. You will see that there has been, because of the Dengvaxia scare, there's a political drama, there's politicized narratives, scientists were discredited, policymakers were discredited, and that leads to the erosion, the fallout unfurling. So we've experienced domino and spillover effects from the measles to the school-based immunization program, while we are trying to mitigate the fallout, here comes the pandemic. So we were challenged, the country was challenged to mitigate these conditions. However, upon reflection, the policymakers also aims to develop different mechanisms to ensure that we still rebuild trust, because it's a huge, trust is a huge issue in the Philippines with all these political controversies. After that, we've proceeded to the empathize phase. We underpin people's experiences. We've basically focused on building empathetic narratives about childhood vaccinations. We specifically looked into purposely selected vaccine-hesitant caregivers, those who have delays or refuse vaccinations. You will see here that the stories and narratives of participating vaccine hesitants really provided an impetus for our intervention development. You will see in the social ecological model that our findings highlighted the layers of social ecological barriers that the caregivers, that led caregivers to feel scared, embarrassed, insulted, and powerless within our healthcare delivery system. This led them towards hesitancy on vaccines. Following the empathize phase, we move towards the design and ideation of our intervention. We wanted to gain user perspective and brainstorm with them not just with the vaccine hesitant caregivers, because we wanted to acknowledge their feelings, we wanted to acknowledge, validate their emotions, but at the end of the day, we wanted to shift the table and ask them, what can we do to help you, for us to welcome you again back to our healthcare delivery system. We also worked with local stakeholders, our healthcare workers, our community health workers, to really ensure that this intervention will not just be another intervention drawn from the IV towers. That this intervention could be used and sustained within the community. So we've, as part of this design and ideation, we uncovered the household decision-making about vaccines in the Philippines. Gendered authority really emerged as a latent source of a power individuals could rely on when negotiating a decision-making. Mothers often emerge as having a less authority than other household members, especially for those household that has extended family members. And fathers were almost universally the clear figure of authority in the household. So our qualitative data from the preparatory phase, empathize phase, to design and ideation really outlined the role of social-cultural context of the widespread consequences of the dengue vaccine controversy across the various population strata, may that be the caregivers, may that be the healthcare workers. These findings then highlighted the potential real-life narratives in developing and honing an intervention rooted in the local context. With that said, we then used these qualitative findings to our prototype phase. So we co-created, we showed our preliminary storyboards. We looked into the power of storytelling. Filipinos are very sentimental. We wanted to have something that not just visible to the eye, but felt like that has this heart-throbbing emotions. And we wanted to show that, and that really emerged during our qualitative data. So during the process, we've co-created interventions. So initially, we thought of, using the human-centered design. We have a priori intervention. We wanted to do perhaps a digital solution, other means of health education, but the participants themselves really wanted to have a story-based, something that they can relate to, something that resonates to their feelings. So we performed think aloud exercises during the entire empathize and design phase. So following each interviews and the focus group discussion, we partnered with local animators just to ensure that we are really targeting, or we are clicking the local narratives. And then we also co-created, as part of the prototyping, we wanted to really develop a new meanings for the vaccines. So we were able to develop an education and entertainment video that features real-life stories, but also trying to move from the traditional meaning of vaccines being safe, effective, against diseases. We were able to, the narratives emerge were in that vaccines as a means for the parents to really demonstrate their love and affection to their children. And parents had, when they think about vaccines, they feel good. So we wanted to show that as part of the emerging voices into the prototype phase. After that, we've tested our intervention. We have tested this one to the caregivers themselves, caregivers of children, of small children. So the intervention was introduced to and tested with a larger sample size. We've used randomized controlled trial, we have intervention groups. Intervention groups received our video, our intervention, and then control groups receive a standard health education package totally unrelated to vaccines. During that time, we utilized COVID-19 education video. And a large feedback was sought in rural and urban communities in a certain province in the Philippines. So as here, you will see that the figure really depicts a positive upward trend in the mean improvement of vaccine hesitancy scales after exposure to the intervention and to the control group. I think the main takeaway there is here in our results is that our intervention really increased vaccine confidence or really boosted vaccine confidence, even if the participants in the beginning do not believe our healthcare workers. Our intervention also boosts positive feelings about vaccines. So this entails the complexity of our project. We run from 2019 and it just ended March 2023. So our insights and ways to accelerate. First is human-centered design and participatory approaches work. And voices of the community people and local stakeholders really matter. And lastly, time, vulnerability, volatility, the roller coaster of emotions of the population. Today, they love vaccines. Tonight, they watch the television, they saw a negative side of vaccines. Tomorrow, they will hate the vaccines. So we wanted to look into the volatility elements of vaccine hesitancy. And that necessitates integrating context and ongoing public sentiments into our interventions. So the need to build culturally tailored interventions are more necessary, a bit more challenging than ever. So I would like just to acknowledge our funding was our work was supported by Bill and Melinda Gates. Also acknowledge my team in the Philippines, Research Institute for Tropical Medicine, and my colleagues at Heidelberg Institute of Global Health in the University of Heidelberg in Germany. And I think that's all. Thank you.
Beautiful. Thank you so much, Dr. Onosa. And I'm really excited about the change of narrative to vaccine meaning, which is really very insightful. Thank you for sharing. So we also have our wonderful next presenter. In addition to all these things we've been talking about, one aspect that is very important again is the HPV vaccination. So we know that vaccines against HPV has proven to be effective in reducing HPV-related diseases and cancers, but yet we're seeing suboptimal coverage in many regions. So our next presenter, Dr. Limaye, used mixed method approach to explore HPV vaccine knowledge and acceptability among young adults living in rural villages in Mysore District, India. So first, a qualitative study was conducted to help identify possible factors that influence HPV vaccine acceptability, followed by a conjoint analysis to measure the relative impact of each factor on their likelihood to vaccine. So let's make welcome Dr. Limaye for her presentation.
Good afternoon, everyone. Thank you for that. And just to begin, I want to say thank you to Sabin, Gavi, and UNICEF for this platform and the opportunity to present our work. Today, I'm representing Public Health Research Institute of India from Mysore. We are a non-governmental organization working to improve the health of women and marginalized groups in low-income communities in Mysore district. And for that, we do research as well as offer healthcare services. So today I'll be presenting a mixed method study that we conducted on HPV vaccination and a new technique we use to understand the knowledge and acceptability of the vaccine. So just at the outset, I'd like to say that I don't have any conflicts of interest to disclose, but the funding for this project was provided by the David Geffen School of Medicine at UCLA. So cervical cancer is the second most common cancer affecting women in India after breast cancer, with nearly 124,000 new cases and 77,000 deaths in 2020. And the numbers aren't looking too great since then either. And this is a completely preventable cancer. So HPV vaccines have been approved in Indian school-age girls since 2008. But the government of India temporarily halted the vaccine studies in 2010, citing safety concerns. And this has spewed a lot of misconceptions in the community, and this has been impeding any other vaccination program that tries to improve HPV vaccine uptake. So additionally, the HPV vaccines that were available were very high cost, which is a major barrier to uptake in a country like India. But there have been two recent developments that reduce the financial burden and have a promising outlook. That is, the first one is Serum Institute of India, which is a prominent vaccine manufacturer, has launched a new indigenously developed vaccine. And this is going to be available, it is already available in a few regions, at a significantly cheaper per dose cost. And then a 2022 update from WHO suggested that even a single dose of the vaccine would be effective in preventing HPV infection as well as cervical cancer in the targeted age groups. So coming to our study, we did a mixed method study to explore acceptability of catch-up vaccination among young women in Mysore. And this was a sequential exploratory design. So the first phase was a qualitative phase that identified factors that influence HPV vaccine acceptability. And this was followed by a conjoint analysis where we measured the relative impact of each factor that we identified. So we identified participants from about 7 villages in India, 8 villages in Mysore district, and 1 village for pilot testing our project. And this was done by convenience sampling because the institute has worked in these organizations and built rapport over time. So our focus group discussions took place from September to November 2022. We had men and women aged 18 to 26 take part in these focus groups, and they were conducted in community spaces. And during these focus groups, we first asked them about their knowledge of HPV, the vaccine, as well as cervical cancer. And then we paused the recording this was audio recorded, the FGDs, and we paused the recording, and for about 20 minutes, we provided an educational session on HPV and cervical cancer. This is some of the sample material that we developed. We also adapted a WHO fact sheet. And then following the educational session, we restarted the focus groups to understand barriers and facilitators to vaccination. So 52 participants took part in 7 gender-stratified FGDs. And we found that the knowledge of cervical cancer, HPV, and the vaccine was low to non-existent in our participants. And then we utilized and adapted the increasing vaccination model as well as the WHO behavioral and social drivers of vaccination framework to explore acceptability. We also used the model in designing our discussion guides. So some of the most prominent attributes we identified were among the thinking and feeling attributes. We saw fear of side effects, perceived personal risk of HPV to be prominent. Among the social attributes, we found family support and peer vaccination role models. And among the logistical attributes, cost, vaccination location, that is whether it's provided by a government organization or a private organization, and then the number of doses. These were there were many attributes presented by a participant. These were the most prominent ones that came up. So coming to the conjoint analysis phase. Conjoint analysis is a marketing analysis technique, very similar to what Dr. Rupali was talking about, discrete choice experiment, where we kind of try to understand how people value certain features of a product or a service. So we use that for the HPV vaccine. So this allowed us to identify the most important qualities that impact whether young women will accept or reject the vaccine. The 7 attributes we tested were cost of vaccine, vaccination location, number of doses, family support for vaccination, friend influence or peer support, personal risk of getting the HPV infection, and side effects of the vaccine. So we presented 8 hypothetical scenarios. And each of these attributes had either a preferable or a non-preferable option that was combined in the various scenarios. For instance, we would say, we gave each hypothetical situation a character and a name. So in this case, we would say Neha, which is a very common name in India. So Neha is at high risk of getting the infection, and the vaccine available to her is available for 2 doses at a cost of 1,000 rupees, but it's being provided at a private clinic. And there are no side effects. She has family support, and she has peer support for this vaccine. She knows peers who have taken the vaccine. So we would give them this scenario and ask them how likely would she be to take the HPV vaccine. So this survey was administered to 101 women in April 2023. And we gave them a Likert scale from highly unlikely to highly likely. And we had them place each card on one of these options. So we provided emoticons to just for easy comprehensibility. So just to recap the methods before I go into the results, we conducted gender-stratified focus groups in young adults or emerging adults as they're known now, 18 to 26-year-olds. These transcripts were analyzed to identify the key HPV attributes, vaccination attributes, and then we additionally identified barriers and facilitators to vaccination among them. Then we did a conjoint analysis to identify the impact of each factor. And then they weighed each vaccination scenario on a scale of highly likely to highly unlikely to understand the likelihood to vaccinate. So just across our whole participants, the age group was about 22.5 was our average age. 2/3 of them were married, and all of them had completed high school. And we just asked them a question about healthcare decision-making in their life, and we noticed that a lot of the women, but also men, reported that healthcare decision-making is done primarily along with other people in the household. It's not themselves that they make the decisions for themselves. So it's usually a spouse or other people in the household that make the decisions for them. And then coming to the conjoint analysis, we saw that social attributes, that's family support and friend influence, had the greatest impact on likelihood to accept the HPV vaccine. Other factors were cost, the risk of getting HPV infection, side effects, and location. Dose number did not have a significant impact on the likelihood to vaccinate. And then some of the strengths and limitations of our study was that this is the first study in India to employ conjoint analysis to better understand contributors to HPV vaccination decision-making. And we used a mixed methods approach, so that gave us the opportunity to understand community-level perceptions as well as individual-level influencers. The limitations are that this was a small sample size, and we used convenience sampling, so this limits the generalizability of these results. And we also found that all our participants were Hindu or practice Hinduism, and so there was that religious homogeneity, and we couldn't explore the influence of faith or religion on the vaccine or vaccine influence. And then we also saw that all of our participants had at least a high school education, so some of our results may not be applicable to lower literate communities. And what are the implications of the findings of this study? So first, we found that there's low or poor knowledge of the disease itself, cervical cancer as well as HPV infection. So we need targeted education campaigns that address fears about vaccine safety. And then engaging young women's families and social networks is critical in HPV vaccine uptake. Exactly what Dr. Rupali was saying, that you have to talk to everyone within the house. You have to talk to the in-laws, you have to talk to the husbands, the brothers, because they're the ones making the decisions. In India, it's still a primarily patriarchal system that runs. So family-based interventions involving men are very, very important, as well as peer education. And then while cost is less important than other social support factors, but it's still a barrier because even the existing indigenous vaccine is costly. It's about 1/3 the cost of what the previous vaccines were, but it's still a significant barrier to uptake. And partial or full governmental subsidization, that is involving it in the routine immunization schedule, would maximize vaccination. And future interventions must engage local stakeholders. Again, engage them at every level, even while planning the vaccination program. Our community health workers, called accredited social health activists, or ASHAs, Anganwadi teachers, who are the rural child care center teachers, local doctors and village leaders must be involved in all stages of the vaccine rollout. So this is our core research team, but this was the effort of many more people. We'd like to acknowledge all our community health workers, all the participants that took the time to answer our surveys, and our student volunteers who helped us design some of the material to make it culturally relevant. And yeah, I'd like to thank you all for listening today, and I'd be happy to take any questions.
Thank you so much. Okay, we're still within time. So our next presenter is the co-director of the Mercury Project, which is an initiative of the Social Science Research Council and is a consortium of over 90 social and behavioral scientists, practitioners, and policymakers committed to identifying cost-effective interventions to build vaccination demand at scale. I'm very biased about this presentation. I really look forward to listening to it. So we're really honored to have Dr. Lanton, who will be giving her presentation on set of baseline and implementation data from selected projects into a concrete set of results and early lessons to stakeholders seeking to maximize impact. You're welcome, Dr. Lanton.
Hi, everyone. It'll be slightly different than that, but hopefully it'll still be good. And I will say, usually I build like a full deck of emotional support slides, and I have a clicker that really gives me confidence. And right now I've got one slide and 6 pages of notes, and we're going to see how it goes. So we'll see. I also want to say, before this meeting, we were having a really interesting discussion up front, and I actually hope we can continue it at some point. I was like, maybe I should redo my presentation. But, the idea that vaccine uptake itself does not equal trust, it does not equal confidence, it does not equal having all your questions answered, and therefore uptake of any one vaccine may or may not be predictive of whether you take any other vaccine seems to me to be really important and underexplored. Okay, so I'm going to hope to make, we'll see how it goes, 3 main takeaways during this. First, just about the value of a framework that we can use so that we have common ways of diagnosing binding constraints in particular contexts, of categorizing and talking about intervention types and mechanisms of action, and then moving towards a comparable set of outcomes. So I'm relatively recently off the plane, running on adrenaline here, but I'll say part of what I did on the way over was I was reviewing a paper that I'm peer reviewing that was a paper that aspired to be a systematic review, and they gathered 50 studies that they thought were eligible, and they weren't actually able to do the systematic review because there weren't sufficiently common outcomes across the studies on health misinformation around the COVID vaccination in particular. And so when we don't do some amount of coordination on common outcomes and have common frameworks from which we're working, we limit our ability to learn across time, space, platforms, and other dimensions of generalizability. So one thing is promoting the value of framework. I'm going to talk specifically about the Mercury Project framework. Second, I'm going to try to make the case for a program of research, so coordinated trials and learnings that allow us to make collective statements. In the case of the Mercury Project, and I'm not sure how familiar everyone is, so I'll give a quick intro in a second. This represents collaborative philanthropy from our donors. We have multiple donors coming into the Mercury Project, and then we have this consortium of 13 teams that allows for shared lesson learning and problem solving along the way, and then coordinated statement making coming out of that. And I will share early findings from 2 studies. Both of those currently are one has the paper under review. One is literally they did their first round of regressions on Thursday, but they felt confident enough that I could at least share that result. And then finally, trying to make the case for more research on demand generation and talking about how we do this to donors and broadening the base for that, right? For donors and decision makers, because I think we need to work on their demand side. And I say that anticipating a question that I think I'm going to get about kind of the future of the Mercury Project, and that's very much about all of us making the case that for all the investment that we make in the new technologies that Rupali talked about, that you have to be investing in the demand side and bringing more people into that tent. Okay. So already the Mercury Project, we're a consortium of 95 social and behavioral scientists and researchers. That's 13 countries working across, 13 teams working across 17 countries, across a variety of different trusted messenger types, online and on platforms. They are all causal studies, 12 are RCTs, one's a regression discontinuity. And I think really critically, they all have behavioral outcomes. So either actual vaccine uptake or online, particularly information sharing behavior. So actual likes and amplification or follows and unfollows from untrustworthy or low quality sources. It is currently a $25 million consortium. It brings together the Rockefeller Foundation, Robert Wood Johnson Foundation, Sloan Foundation, Alfred P. Sloan Foundation, Bill and Melinda Gates, Craig Newmark Philanthropies, and the United States National Science Foundation. And on average, these studies, we're giving about $650K to these studies. The studies cost more than that. So teams are either searching for more money or they came in with co-funding. And I think that's really critical as we talk about building the demand for demand generation research, is that these studies aren't cheap, but they are almost certainly cheaper than doing ineffective programming. But we need to continue to make that case to donors. Our most recent call for proposals, which just closed, I think some people in this room applied, hopefully answers by the end of June. But I will say we got over $100 million in requests for that. That doesn't mean all of those were high quality or went to the external reviewers, but there's clearly demand for demand-side research among researchers, and there's a potential supply for it, and I think we really need to continue to solve the problem of demand from donors and decision makers, other purse holders, both government and non-governmental there. So the future of the Mercury Project hinges on that. And it hinges on us making the case that there's a high ROI in investing in research, which I don't know if is a case that all of us consistently make when we do our own research projects, but I think we need to do it collectively if we're going to keep bringing money into this enterprise. One of my favorite things about the Mercury Project is that it includes both projects in the US and in low and middle income countries. That crosstalk doesn't always happen, although I think some of it's happening here, which is really exciting. And I hope that we can continue to build spaces where it's not just talking about low and middle income countries or Gavi eligible countries here, then middle income countries kind of somewhere in the middle, and then kind of discrete discussions from high income countries. And I think we need to be making this case multiple places, including I'm not hearing that much about the demand side, like in pandemic preparedness conversations or some of these other conversations where I think this really should be part of it. The work that we do in quote unquote peacetime to build demand. Okay, so now the framework, which you've all been looking at. So one of the promises or the good things about the Mercury Project Consortium, we have regular convenings, and we use those to produce collective outputs, and this framework represents both our reading of the current empirical literature, particularly drawing on RCTs around vaccine uptake and kind of tamping down on health misinformation, making a healthier misinformation environment, and the collective wisdom of the consortium. And so we've tried to kind of give a typology of 4 intervention designs or mechanisms for action, and then also a series of outcomes, although I won't talk about those, that I think might be helpful, and we can talk about it maybe offline as a complement or how it might fit with BESD. But we talk about sort of our interventions and categorize all of those in the Mercury Project with these sort of 4 levers, right, that you can use to move people towards actually getting a vaccine. So the first one is lowering the search cost for accurate vaccine information accurate information on both vaccination and vaccine preventable diseases. We talked about the importance of people also understanding the perceived threat from a disease, right? Severity times susceptibility. And so we need information about both of those to be out in the world. I also want to put a plug in for a new phrase or a different phrase, because I think vaccine preventable diseases is going to run into a kind of a branding problem soon, in that we have a lot of vaccines coming online that are not fully preventable by those vaccines, right? It's just mitigating severe outcomes, right? We've got malaria coming online. It's been the case with COVID. It's the case with flu. I think there's kind of a lot of underlying vaccine literacy as these types of vaccines come out that we need to do collectively. So I'll put that out as a challenge. Anyway, so we need to have this information be accessible, be actionable, and we can do that through directly providing accurate vaccine information and then intervening on the information environment, right, to both increase the kind of the volume and the usefulness of the accurate information that's out there, and also work to get people to unfollow or to overall tamp down on that low quality information, which could be, truly inaccurate, could be with the intentionality, it could be disinformation, misinformation. It could be kind of the murky middle of uncertainty, but we need to try to move the information environment as a whole. The second lever we talk about is decreasing the decision costs for deciding to get a vaccine between competing sources of information, right? Which could be 2 people who are claiming they're experts. It could be your doctor versus your mom. It could be a lot of things. And all of that, even just the cognitive and time work of sorting through sources, let alone any financial or opportunity costs of taking the time to do that, to the extent that we can cut that down, we might be able to move people towards vaccination. right? And this can include, to the extent that this is cognitively difficult sometimes to decide between sources of information, people often rely on heuristics and trust in messengers that they trust who in fact may not deliver credible and trustworthy vaccine information, right? So that's, people use shortcuts all the time, and this is no exception. So to the extent that we can make sure accurate messages are coming from folks who are already trusted, and that we're giving people those information or media literary skills so that they can distinguish better between accurate and inaccurate information, that might help, and also using decision support, whether that's kind of motivational interviewing or guided conversations. So third, we talk about lowering kind of the logistical and practical constraints, or costs, of acting on a vaccine intention or moving from motivation to action as per BESD. And a lot of those fall in that social ecological realm, right? So it includes things as simple as, at the individual level, helping people easily identify vaccine sites, making and remembering importance, right? Like making and remembering appointments, overcoming human fallibility, support for childcare and transportation, and then framing, right? So we know things like framing vaccines as valuable assets that can be lost, like some of the text messages and earlier work that say a vaccine is waiting for you, actually has a pretty big impact on people actually seeking vaccination. So overcoming prioritization and procrastination problems. And then our final one, and we've talked about this some in slightly different terms, but we talk about increasing the non-health benefits of vaccination, including the social benefits, which includes things like leveraging vaccine-accepting peers and aspirational figures, increasing information about vaccination status of others, especially where that's positive, right? Letting people know what the norms are in their communities, reminding individuals about their family and community impacts of their own vaccine choices, and sharing accurate information about vaccines within social networks. I've already talked a little bit about the consortium, so I'm going to share two early findings. If you go to our website, you'll see little blurbs on all of our teams. So I'm just going to talk briefly about two. So what we call the Boosting Booster study is one that was a huge study. So they had 3.5 million patients by working with a retail pharmacy in the US. And just before Thanksgiving, which for those of you that don't know is a pretty key travel and family time in the US, they randomly assigned folks to 8 different behaviorally informed SMS messages. They worked on all of those levers, so different of those messages did things to lower search costs, lower decision costs, lower logistical costs. They also partnered with a rideshare and increased social benefits. And across the board, they're seeing within 30 days, folks getting their COVID booster, these were among people who got their first 1 to 2 doses of the vaccine. So this was a reminder specifically about boosters. So it was a specific sample, but in that sample, it increased by 20%. Those folks who got their booster within the next 30 days. So it's pretty good. That paper's under review, stay tuned. We also have a study that we call community-crafted messages. This is working in both Mexico and Brazil. And what this team did was take the standard public health guidance being offered in those nations, worked with specific communities to tailor those messages, and then compared standard messaging versus tailored messaging. And the early results suggest that both for vaccine intentions and then for online health sharing behavior, the community-crafted messages are significantly better. So also stay tuned. Those are the results that just came out on Thursday. Then I just want to say, to make this case for research, because we're all in here doing research, and I know, because I'm sitting in this funding intermediary position, that a lot of you would like to be doing more research, that I think we need to really think about who is worried about unsatisfactory vaccination rates and who should be worried, and do they understand the extent to which demand is part of the problem? Are we making that case in a way that's clear to them, that sufficiently freaks them out that they want to invest in both research and in the activities, the outputs that come out of that research? So to the extent that we can show that the demand side, when it's low, leads to low vaccine uptake, that's a really critical mission for all of us to do. And then who has the power to work on the demand side but isn't yet aware of the problem or isn't yet investing in it commensurate with their level of concern? And I think this is often going to go beyond the Ministry of Health or our traditional health entities, and I think we need to start to get more creative about that. So I think we need to continue to make the case, and somebody kind of said this, a version of this, that just because we build it, it doesn't mean they'll come. And so we need to make the case that for however much we've invested in biomedical and other product producing kind of R&D, including for vaccinations and other protective health products, that we need, that it's, we can't keep having this flawed assumption. COVID proved it. Just because they make it, people aren't going to want it. So we need to continue to make the case for the demand side R&D as critical to the vaccine development process and delivery process. And that's a big norm change and funding change that I think we need to make, both for the sake of vaccination and if we want to see funding mechanisms like the Mercury Project continue. So yeah, it means doing high quality research that clearly moves the conversation forward and that can collectively change programming, policy, and priority setting. I think that I'll go ahead and leave it there because I think I'm at time. Yep, thank you.
Okay, thank you so much. Thank you to my wonderful audience for sitting put. I hope you're enjoying the presentation so far. Quickly, our final presenter, although she's not here presently with us, we're honored to have her pre-recorded presentation from Dr. Heidi Larson, where her presentation focused around the challenges of perceptions and practice of HPV vaccination. So let's listen to her presentation. Thank you.
Good afternoon. Heidi Larson. I'm director of the Vaccine Confidence Project, and I know you've been hearing a number of perspectives on vaccines in general and the HPV vaccine. And in my 10 minutes here, I just wanted to touch on a few of the challenges of public mistrust and the opportunities for building confidence. So I think one of the biggest challenges that we're facing right now is that during the context of COVID in the last 2 years, globally, we've seen a drop in vaccine confidence, not just vaccine uptake, but actually vaccine confidence. We've measured this globally, and because of our background monitoring, we saw, and this was published in the 2023 State of the World Children's Reports, that the perceived importance of vaccine for children has dropped in 53 out of 55 countries. Now, within that, we also did some vaccine-specific questions before and after COVID. And one of the regions that we did this for was the EU. And here we see that between the left point is 2020, the right point for each country is 2022. Across these countries, it hasn't gone up anywhere and went decreased in 17 countries. Now, some of these issues were related to access, but this is a metric of confidence. This is not a measure of uptake. And some of that is in the context of the drop in trust in government and drop in frustrations of the system during COVID. And there are a number of others, historic reasons. But this is also, because we know this now, we need a broader effort, not just in building confidence in a specific vaccine, but when we look across vaccines, it's about rebuilding trust in the system, in the providers, and in the government that delivers the vaccines. I showed you our measurements of confidence in the EU, but this wasn't unique to the EU. PAHO, the Pan American Health Organization, also saw drops in vaccine. Now, in this case, it is a measure of number of people vaccinated. The first slide was specific to confidence, but they're very tied. When people don't have access to the system, it does affect confidence and confidence in the system. So they're very tied, and this is a concern, but it's also an opportunity to jump in and build back. Tanzania also, again, it wasn't just in the EU or PAHO region. We saw a number of countries. Tanzania was one that talked about the impact of COVID. Now, of course, the pandemic was an exceptional situation. We haven't had anything like it in 100 years. But what it did do was exacerbate what were already underlying concerns. So this is something that I'm sure has come up in the context of the discussions in the conference, but I think there were also very specific things that came up related to HPV vaccine. Now, this was just before COVID, where we published a review in Europe of what was driving public mistrust in the HPV vaccine. And as you can see, the different colors of different countries, highly, highly varied across countries. And this is no surprise to any of you, but how we unpack what's driving these concerns is super important in terms of knowing what to address. Information issues were indeed a big issue. People didn't feel like they had enough information, the right information, or scary information. Concerns about vaccine safety too were our dominant concern, and that's true with vaccines more broadly. In our global vaccine confidence monitoring, importance is generally high, but when it comes to asking the same questions about safety, that's one of the more frequent reasons that people hesitate. Not the only one, certainly. And then with HPV, we have the additional issues around sexual health, anxieties, and that age group. The good news in Japan is that after nearly 9 years of a suspension of the government's recommendation, proactive recommendation of the HPV vaccine, they did finally agree to start to re-promote it, and that was prompted by, as I'm sure a number of you know, some girls reacting with neurological shaking and eating disorders and a number of different issues, but they were deemed not caused by the vaccine, but in fact it was related to the anxiety around the vaccination experience. But anyway, the good news is that the recommendation is back, but there are still a core group of members of the ruling party who are anxious about it contributing to promiscuity, which is we've seen this in a number of different countries. Denmark was one of the countries, like Japan, and in fact, actually after Japan, and some of this was a viral spread of concern, girls seeing what was going on in Japan, and there was a viral spread of some of these reactions. But how Denmark, in fact, rescued a lot of these concerns that the girls had, that their reactions, their mobility issues were because of the vaccine. And actually, there was a call to the EMA, the European Medicines Agency, to review the safety, which they indeed did, and found there was no reason to suspend the vaccine. But what brought the system back was engaging the girls themselves in the strategies, in the creative ways of building confidence back. So the involvement of girls was absolutely crucial in the design of the campaigns. And I think this is a global message, and I know a number of countries are doing this, but it really made a big difference. And I think Japan will benefit from that too. And one of the things that's WHO has, and particularly GACS, the Global Advisory Committee on Vaccine Safety, has increasingly seen that it's not just safety concerns are not just about the product, the vaccine, but the vaccination experience. And given the number of countries that these reactions happen, Japan, Denmark, Ireland, Colombia, and other countries, they recognize that this actually is a an anxiety reaction, and this is a really important manual that they issued. They're calling it ISRR, the Immunization Stress-Related Responses. It's a really important manual for healthcare professionals to prepare and try to mitigate these things. So if you want to build confidence among the healthcare providers, which is really important, because if they know that there are the anxieties, it makes them sometimes anxious. So this is a very important manual that people should be aware of. And one of the main points in the manual is that we need a better patient experience, particularly when girls are anxious. But on the issue of girls' perceived promiscuity issues and rumors about sterilization related to HPV, which we've seen in some countries, my last slide is really, and I'm sure this has come up before, it's so important that we get gender-neutral vaccine, HPV vaccine policies. This is really my last slide because I think it's one of the most important things now moving forward. It'll mitigate a number of the concerns in certain countries. Why just girls? We've seen that with tetanus historically. But I think this kind of gender-neutral approach and will change some of the perceptions. This is a good paper just came out a couple months ago and maps out some ways. So thank you very much. I hope I kept it to my short time and it somehow added to the other perspectives of the group. I'm very sorry not to be there. Looks like a really excellent conference. Thanks so much. Good afternoon. Heidi Larson.
All right, thank you so much. So now we have 17 minutes left to ask questions. So I'm going to start with my wonderful panelists. So for Dr. Richard, I have a couple of questions too. So what are the key recommendations for countries to consider in creating and sustaining demand for vaccine before, during, and after epidemics and outbreaks, given a lot of work you've done and seeing in the midst of all the mistrust going on? So what can we do better and differently? My second question would be, are there any community-based insights that you'd like to share with us on, of the importance which countries must really consider in programming for vaccine demand during outbreak and epidemics? So I also have some questions for you, Dr. Rupali. Yes. So following your presentation, would like to know which community voices should we engage with now to prepare communities for new vaccine, given the new vaccines coming up or in the pipeline. And last but not the least would be, what are some ways communities has combated rumors in relation to new vaccines? So we'll be happy to hear your response on that. So for you, Dr. Renosa, so caregivers and families felt scared, powerless from the presentation. They felt insulted, embarrassed in relation to the vaccine. Could you please elaborate how you incorporated these overarching emotions into your developed intervention? And based on your experience and the insights gained from this project, what recommendations would you offer to other researchers aiming to use human-centered design driven interventions to address vaccine hesitancy in their respective contexts? And for you, Dr. Karamaye, based on your findings or your study findings, what are some recommendations to improve knowledge about HPV, cervical cancer, and the HPV vaccine in low-resource settings or among low-literate communities? And what are the roles of community collaborators or local stakeholders in increasing HPV vaccine uptake in a country like India and other developing countries? And Dr. Lanton, so how does the Social Science Research Council envision the continued growth of the Mercury project and its consortium? And who are the stakeholders of the MP findings or work, and how are you engaging with them to move policy and program development forward? So I think we can take the questions together. Maybe I can ask the audience so that we can just close up with that. So now I'm going to invite the audience. So if you have a question, please walk up to the mic, state your name and your country, and then your question. Thank you.
Hello, well done for the presentation. I'm Dr. Navneet Bichha. I'm from Nepal and currently a postgraduate fellow in implementation research under the WHO TDR. I have two questions. The first question is, during COVID, we saw that procurement of the vaccine was difficult, and that affected vaccine delivery in low middle income countries. Even though when we had good COVAX system. Now how can we develop a future trial ecosystem? As Dr. Rupali mentioned that one of the key intervention or drivers will be introduction of new vaccine. So how can we, in countries in the low middle income countries, how can we further build a better trial ecosystem? Because now the WHO resolution wants to implement a trial ecosystem across low middle income countries. So how do we adapt to this resolution, number one? Number two is that in context to HPV vaccine, we see that one of the key barriers is the caregivers are very resilient with the vaccine uptake due to certain social stigma like infertility, and this may be one of the key barriers when we roll out HPV vaccine globally as well as regionally. So how can we intervene in these elements? Because this is something that we have to counterattack very seriously, because in countries like India and other developing countries like Nepal, Bangladesh, we see that this is one of the big cultural stigma. So how can we build better intervention, even though we have like family education and family interventions? How can we better this barrier? So thank you.
Thank you so much.
Thanks very much to the panel. Very interesting questions. My question goes to Dr. Limaye. I hope I pronounced your name well. Yes. I was very intrigued by your presentation about the conjoint method for looking at factors that girls prioritize around HPV vaccine. And I'm wondering, were there any new insights that this method provided? Because traditionally, people would use maybe regression models to look at key factors that either drive vaccines or hesitancy. But you're bringing in this market-based tool or approach. What new thing did you find when you compare it with what has been the traditional regression models and papers that have used that method to look at the question? Thank you.
Thank you.
Good afternoon. My question is for Dr. Mark. I'd like to ask on the evaluation framework on how do you define the construct of vaccine confidence, particularly in looking at how this was disaggregated and seeing how narratives say on trust in the decision-making process, which I think is very crucial in the Philippine setting, how this narrative has somehow shifted because of the intervention. My second question is on the durability of the impact of the intervention as well. Were you able to follow up and see the compliance of parents after exposure to this intervention if they finished the entire childhood immunization or even the cross-protection to other antigens, say COVID-19? I'm June, by the way, from WHO, also from the Philippines, so this is very interesting for me.
Thank you. Okay. So, Dr. Okay, please.
Thank you. I'm Danish Khan. I'm Social and Behavior Change Specialist with UNICEF India. I have two questions. One is related to this whole AI5 thing. what should we do to orient media about it? Because one small incidence, vaccine related, whether it is AFI or not AFI, but when it is reported in the larger media, even in a small incidents, looks very big. And we have seen in India and other many places where the headline is like this, that after vaccination, child died. So even a child has died because of many other things. How we can orient a large media into it? Because that one wrong information goes up to, it can goes beyond one vaccination. The other question or just a reflection is related to another community which is being have emerged in last 2-3 years. It's like social media influencers. So lots of people are getting influenced by Instagram influencers or YouTube vloggers. I mean, this is an area which is highly untapped, and lots of decisions are being influenced nowadays by these people. So the kind of information they have provided, sometimes they are influenced by some products, they are being directly or indirectly paid by those products owners or producers. So how, and this is an untapped community. And although the influencers may not be living in my community, the influencer may be living in a very faraway place, but I am coming from a very remote and tribal state of India, and I can still see that women are getting information from a vlogger of Delhi. So I mean, that community and that influencers, I think it is something, an untapped area for us.
Okay.
Thank you.
Thank you so much.
Okay, I will start by giving my personal insights on the last question, and then I get back to you. Then I think if you look at all health programs, it's true that the health sector or ministries of health and other agencies in health tend to work with media. But if you try to interrogate, our media engagement is not all that effective. We tend to think, even when they come to us, we tend to undermine them. We don't look at them as peer, as colleagues at the same levels, as these are colleagues who are in the other side of their profession, who are practicing, and they have come to us. We don't give them the due respect they deserve. And we usually think it's a favor for them to share with them information. I think ministries should ensure that from the strategic point of view, media engagement should be one of the prioritized core intervention areas during rollout of any health campaign of any nature. So, and looking at the media practitioners as fellow colleagues who are part of us in the advancement of public health. Because without them, without understanding them, without working with them, without respecting them, renders public health efforts non-productive. And the other key issue is, I think many governments don't have good insights in how to work with the media broadly. Now bring it in the space of new media, or what many people call social media. We tend not to invest in there. We tend always to, it's always a top-down kind of communication, which is very sad. And because many countries or many people rely on governments when it comes to vaccine-related information and packaging. So it's better for us to learn dynamics, how we need to leverage on the minority who are on new media or social media, and also learn the tricks. Because new media is growing, it's very difficult to put a stop on the bloggers and all that. So we need to find a way how we can have our own influencers through this kind of channel to be able to leverage on whatever work that we are doing. The other question, I think for all the presentations we have had, that they are trust-related issues. And during epidemics, it is very evident that people will lose trust in government, people will lose trust in scientists, people will lose trust in health workers, because they know that the scientists and health workers are the ones who are fronting most of these issues. So the hardships in many countries, the hardships, the public health interventions and measures that are very stringent have been proposed by the technical people who are the scientists. So now communities tend to rely heavily on the non-health actors or practitioners. And it is a weakness on our part as scientists because usually we tend to look at our colleagues who are not in this other profession as people who are not of, we don't look at them as equals. So, but of course we know, as I said earlier on, if you visit many countries, public health has been medicalized. You don't have a 40 or 60 or 50-50 balance between social science and these other sciences that actually synergize public health practice. So the social science bit requires us to bring more people to be at the forefront because communities or individuals in communities, if they don't believe in what I'm saying, if they look at my king or my church leader or my third opinion leader in my community doing something or talking to them about vaccines, chances are high that they'll do it. So the detailed mapping of the social networks in all communities where we are coming from and being in a position to rely on the social networks to identify people who matter, who are not necessarily into the direct implementation of these programs. I think it's something that we need to think about. And then lastly, what I've seen in countries, including our own country, is that even when we come to conferences like this, we tend to talk about communities, putting communities at the center stage, community engagement and all that. So we have failed to transition from theory to practice or to action. When we go back, our programming is still skewed towards clinical, so which is really a very big challenge. So, and I think my last takeaway would be that it would be better for us to revise mechanisms, how countries will swing into real action of putting communities at the center. Beyond documentation, beyond talking, and beyond writing and documenting this as a core area without letting it happen. Thank you.
Okay, thank you very much.
I know we're almost out of time, so I will go very quickly. So I want to make sure all of the panelists have a moment. Yes, I will. So I'll just answer two of them. One of the questions focused on how do we combat rumors that are happening in the community. And this is great. So a colleague of Prachi and I is also going to actually present on work that was funded by SAVIN that focuses on misinformation for healthcare workers at all levels. And we essentially used debunking, we used inoculation to develop a synchronous and asynchronous free training, which, by the way, I should say, if you're interested in any of our work from Hopkins, we do have tote bags, and we have a postcard that actually has the QR code for the training. And my colleague in the room next door is actually presenting on our data visualization website, which is also free, called ViewHub. So I'm just promoting that so you can have a free tote bag at the end. The only other thing I wanted to say, I thought there was a question that was so interesting about influencers. And again, Prachi, who's in the room, and I were very fortunate that we received some funding to actually work with social media influencers. And these were in minority populations in the United States. And we actually are about to finish a systematic review that looks at what can we learn about influencers. And there's actually not a lot. There's not a lot of standardized metrics. There's not good ways for us to think about how to recruit them. And so, and I'm sorry, I'm trying to find the gentleman that asked that question, but there's a huge untapped potential there from a public health perspective, is how do we make these collaborations with individuals that do hold this social media influence that might not be health individuals, right? That might be blogging about beauty or videos or movies. But I think partnering with these types of individuals that do have this influence is really a great new way for us to think about a partnership. But I'll stop there because I want to make sure everyone has time.
Okay. So I'll do the touch based on the fear and embarrassment narratives from the side of the caregivers. We incorporated that narrative into our real life stories. We wanted to show how these narratives changes over time, because basically I have to be blunt that our systems are built into a blaming culture. When a caregiver comes in delayed with vaccines, healthcare workers oftentimes dismiss people, or sometimes when caregivers are hesitant, we definitely be combative and saying that, oh my God, you're hesitant, without even giving information, and that acknowledging that their fears are valid. So we wanted to show that. And also, I would also wanted to include also that the whole system is quite problematic, because the healthcare workers vaccine programs is just one vertical program. Healthcare workers in the grassroots levels are delivering several vertical programs, so they are demotivated as part of caregivers feeling scared, feeling embarrassed from the side of the healthcare workers. We also need to invest on our healthcare workers in the grassroots level. Second, and that also leads to the question of June on the measurement of vaccine for our randomized controlled trial. It's actually one you touch base literally on our critical limitation of the study. To be honest, we really just focused on the change in attitudes and vaccine intentions, because financial-wise, measuring the outcome of primarily if the vaccine uptake takes years, takes time, and the whole human-centered design is quite messy and requires a lot of years of testing. So that leaves us to more, moving forward, we wanted to roll out the randomized controlled trial in a nationwide perspective, looking also into the vaccine uptake. And also the third question is, I just wanted to reiterate on, to emphasize good question about vaccine moving forward. I think we should invest on untapped resources from our low middle income countries on vaccine development. We should facilitate vaccine development, so that at the end we will not, from the low middle income country, we will not literally beg high income countries to give us their spare vaccines. Thank you.
Thank you. I'm going to quickly, is this on? I'm going to quickly go over the questions posed. So the first one was about how can we improve knowledge in a country like India. So like I mentioned, there are patriarchal systems in place, and we have to use the system that's in place, so understand the cultural context. We have to form the messaging around this cultural context. For instance, the woman is the primary informal caregiver of the family, so equate the health of the woman to the health of the family, and build your messaging around that. So there are things like that you can use, but involving men, I've realized, is primary in working towards this, because a recent systematic review that we did saw that in all of the LMICs, any family-based interventions on HPV, we found just one intervention that had used fathers as participants to check for HPV vaccine uptake. So that's one of them. And then the next question was about how to improve community engagement at the local level. So like Dr. Richard mentioned in his presentation, that we have to be in touch with whatever's happening at the ground level. And this is only possible if we find trusted messengers. We cannot be the messengers ourselves. Our positionality as healthcare professionals is actually at a disadvantage when it comes to vaccine hesitancy. So we need to engage with local trust holders at all the way from the planning stage to the evaluation phase of any of the vaccine programs. And then coming to one last question about what new insights the conjoint analysis could have provided compared to previous models. So previous models mostly focused on cost as a barrier, because we're a low middle income country. And the cost of each dose is about 2,000 to 3,000 rupees, which is about $30 in US dollars. And this can be a family's household income for a month, so nobody was going to spend that amount of money. Now with indigenous vaccines coming up and the possibility of it being part of the national schedule, which will subsidize the costs, shows that none of that matters if there's no social support and peer influence. So peer influence is surprisingly a very big factor that we learned this time. Because of the stigma surrounding HPV vaccines, nobody was ready to tell others that they've taken the vaccine. But this project showed us that peer influence overcomes, anything about peers would overcome the cost barriers that are in place. So, thank you.
Thank you.
All right. I tried to bundle in the answer to the first question partially in what I did, which is, the future of the Mercury Project, I think, hinges on continuing to make the case that there is a high return on investment for investing in not just high quality research, but then in consortia or programs of research like we've done, which hopefully I did a little bit of today and continue to do. We think we have a really good infrastructure that could also address other questions, but in terms of the focus on vaccine and health misinformation, that's very much about maintaining and growing the donor base that we have. Each of our 13 studies that we currently support is working with a different set of stakeholders, which in different contexts is journalists, social media micro-influencers might be of interest, radio DJs, doctors, nurses, community health workers, retail pharmacies, and STEM college or university students. And then each of our projects themselves engages with various MOH or Ministries of Education as their primary stakeholder. But then part of the promise of the consortium and the fact that we are trying to be greater than some of the parts of those individual studies is that higher level of influence. And so we are doing things together like we wrote recently a letter of support. The WHO, maybe some of you saw it, just passed a draft, or now no longer a draft resolution, is a real resolution on incorporating behavioral sciences into their practice. And so we have written in support of that and encouraged them to use our framework, or at least an evidence-based framework, to really structure that evidence repository to make it easier for people to find it. But I think a lot of it goes back to what Kevin Starr calls the doers and payers at scale, and that's who we all need to be engaging with, which is usually going to be government, private sector, and in some cases multilaterals. So we're beginning on that, but I think the more we can do together, the better.
Thank you so much. So on that note, I would like to close the session for today. I would like to thank our esteemed panelists, our distinguished guests for participating in this session. I hope you've really gained invaluable insights to continue our work in improving demand for live-COVID vaccine and other vaccines in general. So on this note, I want to say thank you so much. And there's an ongoing session, I think it's the poster presentation happening right now. Please feel free, to go see that it's beginning at 4 o'clock, I think about now. So thank you so much. Do have a wonderful evening. Yes, please, can we have a group? Yes.